Sphygmomanometer, manual mercury sphygmomanometer. This is the gold standard actually of measurement of blood pressure. You will also find similar equipment but without the mercury meter. The rest of it is the same, just a meter attached to it showing the pressure rather than that. Okay, that's an aneroid. And of course you can have digital ones, right? But this is the best. Most accurate of all that. Of course, if you want a further, more accurate one, you need to put a catheter into the artery. That you don't want to be done all the time, right? Yeah, but it can be done. It is done under certain conditions in intensive care and so on. This is a non-invasive method. Out of the non-invasive methods, the mercury one is the most accurate and the gold standard. Right? So this is what we are going to look at today. The equipment that we use, a cup, a cloth cup, inside which we have a rubber cup. You want to feel it and see? What's there? Yeah? Feel that? Want to feel it also and see? Right? Okay, of course you will get to use this later on, right? So inside here, this part is rubber, right? You felt that. This part is just cloth. This rubber cup is connected to two tubes. One tube leads to the reservoir of mercury. Can you see? What you can't see? Come in front. Can you see? Who is hiding behind? Ah, right. Katka has seen, so it's all right. Can you all see? Okay. So any increase in pressure here in this cup will be transmitted to this reservoir. And what it will do is, when the pressure increases, it will drive the mercury column onto this and up. Now let's see whether what I'm saying is okay. The other tube connected to the rubber cup is connected to this bulb, which has a valve here, which you can open and close. And if I close it and squeeze this, what happens is air is pumped into this cup, right? Okay. And you can open this valve and you can let it go. But now, I said if I increase the pressure here, the mercury will rise. Right? So yeah, is the mercury rising? Something wrong? Is it? Why isn't it rising? Okay. It isn't rising because we have a lock here. Can you see this one? That's this little gadget is a switch. It's a lock which separates these two. Now if I turn it this way, I have opened the lock and okay. Right. So when you get your instrument, it should be ideally locked, so that the mercury is not going all over the place while it is not being used. And when you finish using also, before you close the instrument, make sure that all the mercury has gone, it has come down to zero, everything is in the reservoir, and then you lock. Then only you will close it, not before. Right? Okay, so that's what I wanted to show. So now it's full of air, it's locked, and I can open and just squeeze it out. What happens is that everything will escape through this valve. Right. That's the instrument. And what we do is actually, the theory behind it is that we apply this cup over an artery and inflate this. When the pressure in the cup is higher than that in the artery will get squeezed, compressed, and there won't be any blood flow after that. So if you look at the distal part, there is no blood flow. Right? This is what we want to do. And that pressure in the cup, which is necessary to compress the artery, we can read off because we know here. That's the very brief theoretical basis of this instrument. Right. Okay. Now I will show you the technique, and then one of you can actually do it here. Right. Is it easier for you to see me doing here, or should I go there and let you come here? Maybe I should go there. You all can be at a higher altitude. Right. And yes, see what I am doing. Right. Now I need a volunteer. Who wants blood pressure taken? Yes. Come. Yeah. The blood pressure can be taken in any position, right? Lying down, standing, and but you know that there is something not quite right with the standing, which we discussed yesterday.
Yes.
So it will not be the best, right? So lying down or seated, one of these two. But generally in the clinic, we will take the blood pressure seated most of the time. Lying down, it will not be much different. But there are situations clinically when you want to particularly do it when the person is standing up also, in addition to doing it seated. Can you think of a situation? Why do we want to do that? Yesterday we talked about some mechanisms. What might we detect if we do sitting down and standing after that? Postural. Yes, postural, good. Reduction in blood pressure. Normally it shouldn't go down, right? But if you can show a reduction in blood pressure when you stand, what do you call that? Postural? What do we call the low blood pressure? Hypotension. Postural hypotension. When we want to show, demonstrate the presence of postural hypotension, we do that. And why would that happen? Because those mechanisms that we talked about yesterday are not occurring. Yes, usually problems with the autonomic nervous system. Right, we won't go into the details. Right, now, okay, I will just show you the technique now. Now we are looking at the technique, not the full thing of doing. I'll come back to that later. Just the technique. Okay, so as we said, the theory is that we have to compress the artery, and we said usually we use the brachial artery. And this particular cuff is for the arm brachial artery. We can't use this cuff for every artery or every person. If you use a limb, this rubber part of this cuff should be approximately 2/3 or 3/4 of the circumference of the arm or the limb, right? Then we get a correct one, right? So this we will not use for the thigh because this is too small. This we will not use for a baby, too big, right? The cuff sizes vary. This is the standard one is for the arm because that's the place where we do that. Okay, so different cuffs for different purposes, different sites of taking blood pressure. This is for the arm, right? Now, next thing is, of course, as you said, we have to compress. We have to make sure that we apply this appropriately. Now, regarding the arm, how do we apply it? Now, there are 3 things to remember. You will see that in the here there's a label, arrow marked here, and artery. That's approximately the middle. Most cuffs have this. Even if we don't have it, doesn't matter. We are looking at about the middle of the cuff. What it means is that this mark or the middle of this rubber cuff must overlie the brachial artery. Now, where is the surface marking of the brachial artery? On the arm? See, that's there, but that's not the place where we are going to. Yeah, it's medial. It comes medially below the biceps there, and of course it comes more anteriorly in the cubital fossa. Right. So this needs to be there. Okay. Now, before that, how do we apply? Do we apply it over our clothing or not? No. Again, for the same reason, we need to observe. So we need to make sure that the clothing is up there. Right. In this case, okay. Alicia has already helped me. Right. Well, okay. Now before that, one thing I will show you, if you don't mind. That's an elastic thing, right? If you push that one, right, what might happen?
Compression.
It will constrict as well. Fortunately, it's not very tight, so it's all right. Right. So you need to be right? Not only push, you make sure that there is no clothing over the arm, but also make sure that the clothing, any form of clothing, doesn't constrict. So if it is a tight one, don't, very constricted here. For today, for this practical, okay. If it is inconvenient for you to remove your top garment, yes, it is okay. But in the clinic, if it is a tight clothing, what do? You ought to actually remove it. Remove the clothing. It's not just making this visible by somehow pushing the clothing up. Yeah, and it will constrict. In this situation, we can. So one thing we need to know is, right, is there any other constriction? No. Is the arm bare? Yes. Those two things are. Then, as I said, the first thing that we need to do is, how do we apply? We apply the cuff with the center of the rubber tubing over the artery that we are going to compress. So, right? Somewhere there? Okay? Right? And this is well closed. And, okay, right. So, first thing about the application, yeah. Second is, this cuff shouldn't be too tight or too loose. Too tight means it's not the pressure that is constricting, our application of the cuff itself will be constricting. We don't want that. If it is too loose, what happens is that there is enough space between the cuff and the skin for the balloon to cuff to expand. It's not compressing the artery, it's just expanding outside. We don't want that also, right? So how do we make sure? Right. Once you apply the cuff in the proper place, just put in a finger. The finger, you should be able to insert a finger between the cuff and the skin easily. That means it's not too tight. Then how do we make sure that it is not too loose? Hold it there and give it a tug. If it comes down quickly, that is too loose. Of course, don't pull it very hard. Anything will come out if you pull too hard, right? But it's a tug. I will give you a tug. It's not too loose. Okay, so now it's all right. Okay, that's the second thing. First thing was, first requirement was the position of the middle of the cuff. Second requirement is not too tight, not too loose. Third requirement is we need some space here because we are going to do things there in the cubital fossa. An inch or 1.5 inches, depending, of course, on the length of your arm. If it is long enough, you can have 1.5. If it is not so long, of course, with this cuff you may not. So we have about an inch. I would have actually preferred even a little bit more space here, but of course your dress is there. Right. Okay, so we have applied the cuff. Now what do? We do this in the arterial pressure. What we want to finally find out is what's the systolic pressure, diastolic pressure. That's how we express our pressure. We know that. The reasons why we know. Maximum and minimum, we can give one. Right? Now, recording these two pressures, we do it in 2 steps. Right? 2 steps. First step is by palpating the radial artery, and second step is by listening, auscultating over the brachial artery in the cubital fossa. Now, these two are 2 steps of the same process, right? They are not 2 different ways of measuring blood pressure. One way of measuring blood pressure with this, which has 2 steps. So, never ask, how shall I measure, by palpation or auscultation? That's not a valid question. It's like asking your, how shall I drive my car, with my arms or with my feet? What is the answer? Unless somebody here is doing it with just one. All right. So never do it say, is it by auscultation or palpation? It's the same. Both have to be done. So, but we do it in a particular sequence. Palpation first and then auscultation. Okay, so what we do is, now is the time to open our lock. Lock, right? And then we close the valve. If, you can hold it in a way, but when you practice, you can try this. Hold the bulb in your palm and use these 3 fingers, medial 3 fingers, to pump. Leaving, right? Okay? Leaving your thumb and the index finger to deal with the valve. Because I'll see why it is so in a minute. Right, so I keep it, close the valve. When you close the valve, don't put your and all your muscles into it, and it's not necessary. You can actually close it this way, that is enough. Or even with 1 finger, that is enough. This is a good lock there. And it will not leave. That is because we don't want to, if you lock it very tight, you also need to have both hands there to open it also. We don't want that. We want to open it, and we want to open it very slightly, as we will see. Right. Okay, so got the equipment ready, right? Lock open, valve closed. Next is I palpate the radial artery. You have done your pulses in clinical skills? Yes? No? Yes? No?
No, not yet.
Not yet. Right. Okay. You know where to palpate the radial artery? It is on the wrist over the radius, right? Distal end of the radius. You have these tendons there. What tendon it is? I have forgotten now. What is the tendon there? Right. Just lateral to the tendons. Flexor, carpi, radialis. Okay. And also the next one, palmaris, longus. Right. Okay. I do still remember some of them. Yeah. Okay. Just lateral to that. When you feel with your 3 fingers. You learn more of it, and you use the tips of your fingers. Not this way. Not this way. Because tips of your fingers are the most sensitive. Right? So, bend them, right angles. Perpendicular to the fingers, perpendicular to your pulse. Right? And don't press too hard. If you press too hard, your pulsations of your fingertips, you will feel, and not the pulsations of your wrist. Particularly if, sometimes it depends on the individual. The pulse can be very well felt or not very well felt. There's nothing wrong with that. That's an individual variation, right? So just light. Right. Okay, that's about the pulse itself. So now I feel the pulse, right? I feel the pulse. Okay. Right. That's right. Now I pay attention to the pulse, not to this instrument initially, but right. Once I feel the pulse, I pump, and it should be rising there. I'm not worried about that for the moment. I'll raise it. Now I don't feel the pulse. Right. Okay. See, I'm not particularly interested in the height of the mercury at the moment. First, I'm interested in the pulse. At the same time, I'm pumping up the pressure. Yeah. Until I say, oh, I don't feel the pulse anymore. Now I pay attention. And now what I do is, I open this very slightly. Can you see the column going down? Is it regular? Is it going down regular, uniformly?
Yes.
Is it going down very fast? No. That is what you want to do until I feel the pulse has come. Okay, I made a note of that pressure, and then I open the valve completely. So what did I feel? Radial pulse. I felt the radial pulse, right? Inflated the cuff until I couldn't feel it, and then reduced, right? Till I felt. So when I'm reducing it, I have 2 things to look for. Am I feeling the pulse? What is the pressure? Both these are concurrently, at the same time I'm making. As soon as I feel the pulse again, why did the pulse disappear?
Compression.
It was the compression, Then I release it. The first time I feel something, is when the pressure is slightly lower than the pressure, maximum pressure. Hmm? So what that pressure that I recorded here, whatever it is, as soon as I felt the pressure, the radial pulse again, is the approximate systolic pressure. Approximate systolic pressure. Right? Okay. So that's the first step. I have an approximate systolic. I don't have anything about diastolic. Approximate. Right. Next step. Okay, that's the first step. Approximate. Next is the auscultation step, not the different procedure. Step of that. Right. Can I have the stethoscope? You have used the stethoscope?
Yeah.
To listen to heart sounds?
Yes.
You know how to use this one?
Yes.
Which way to use this, right? It's anteriorly. The earpiece is going anteriorly, right? Yes? Okay. Okay, you. Next is to locate the brachial artery. The radial artery is generally very fairly constant in most individuals, the position. But the brachial artery, the position changes. It's not constant in different individuals. The position is a little bit variable. Radial artery almost always, well, you can have an aberrant artery in a rare situation, but generally the position you can actually say, this is the place. In all of you, it will be there in that particular case. Brachial artery is not so easy to find because it's variable. Generally, it is in the cubital fossa, it's just medial to the biceps tendon. Just medial to the biceps tendon, sometimes even under, a little bit under. Right? So first thing, now we want to locate the position of the brachial artery in the cubital fossa. Right? So how do we do that? First thing is to locate your tendon, biceps tendon, because we know that it's a little bit medial. Tendon is very easily identifiable. Now, how do you identify the tendon? If you do this, try. Can't identify the tendon. Can you? If you completely extend your arm, no. So what you do is you bend your arm by about 20 to 30 degrees. Can you identify it very easily? So you bend it and you bend it. Right? You want to try? I say, fully extended? No. Bend 20 degrees or so? No, it's gone away. Yes, right. So bend the arm, locate it. Locate it, and now once you have located it, you can use your thumb, either way. That's the thing. I can feel it there. Sometimes you might have to push this tendon laterally a bit so that you get under. Okay. You should be able to feel it there. Right. Sometimes it's not felt there. As I said, the site can change. So then you may need to explore a little bit further up, still on the medial side of the biceps, and so on. Here I can very easily. All right. Okay, that you can practice when you actually do it. So now I know the site. Now I'm not going to feel the pulse, but I just got that site. That is where I feel it well, because that's where I'm going to listen now. Right. So now I keep the stethoscope there, and you use the diaphragm. You have used it. You said the diaphragm and cone. For this one, we use the diaphragm. You know how to make sure it's a diaphragm?
Yes.
It's open because you have used it, right? So you can just give it a tap. Of course, put it in your ear, right? And tap, and you should hear the sound. So this purpose, I'm not going to put it in my ears because I'm explaining. But you'll have to imagine that they are in my ears, right? Okay, so I have kept it and I'm listening. Imagine the earpieces are in my ears. Do you expect to hear any sound? Do you think I'll be hearing some sounds? Right?
No.
Because the artery is there? What about the vein? Will I hear any sounds in the vein then also? Right, you don't hear anything. Huh? You don't hear anything because normally fluid flow, when it is laminar, it does not make a sound. Right? Okay, we like drains, right? Monsoon drains. If a little bit of water flows, you know what laminar flow is, right?
Yes.
In orderly way. Does it make a sound? After the rains, when the water goes this way, like in a turbulence, then from home you can hear, right? You don't even have to go near the drain, right? Sound. Now, in the arteries, fortunately, the flow is laminar. There is no turbulence. No turbulence, laminar, and therefore, if you listen, you won't hear anything. That is why we need to find out where the place is. If we could hear, obviously I don't have to feel it. I can just go on doing this. Where is it? Right. That's why we need to actually feel for it first. So now I have kept the stethoscope there. Don't hear anything. Right. Now go back to this. Close. Just a little bit. No need to tighten it. And now I'm going to inflate it. Remember, I got a reading there about 100 approximate. So now I quickly inflate to about 130. That is the approximate systolic pressure plus 20 to 30 millimeters mercury. Okay. Now you are imagining that my stethoscope is in my ears, right? I've gone quickly there, looking at it. And now, still I don't hear. Now I again, can you see it going down? What have I done? Open this very slightly while listening. Right, okay, I'm good. While listening, what I will hear is, so no sounds heard to start with. I quickly inflated to 130 in this case. I'm still not hearing anything, right? Now I'm lowering the pressure. Lowering the pressure. Obviously, the pressure here is higher. Is there any sound I can hear? No, because there's no blood flowing. Doesn't make. Yeah? So the drain doesn't have any water, obviously, also doesn't have any sounds. Okay. When I reduce the pressure at one level, I start hearing sounds. One per cardiac cycle. Tuck, 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 tuck. So now, at that, when I start hearing the sounds, what does it mean? The compression is not complete. And why do I hear? Because if the drain is narrowed in one place, what happens to the flow in the, after that, it becomes turbulent, right? It will make a sound. So it's partially compressed, not fully compressed. Therefore, turbulent flow, I hear sounds. So what is that? The pressure at which I start hearing sounds, tuck, tuck, one sound for each cardiac cycle, is the pressure, systolic pressure, because when it comes before, slightly lower than the systolic pressure, what happens to the artery? Sometimes it's open, sometimes it's closed during the cardiac cycle, isn't it? When it is open, some blood goes. Not completely open. Right. And I further reduce the pressure. Sounds get louder and finally they disappear. Why do they disappear? This pressure is not compressing at all. The artery is just like normal. And so what is that pressure? Diastolic pressure. So systolic pressure is the pressure at which you start hearing the sounds. Diastolic pressure is the pressure at which you stop. The pressure, the sounds disappear. These sounds are called Korotokov sounds. Based on the intensity of the sounds, we divide these into phases 1 to 5. We don't want to know all about that. That's theoretical. But what we want to know is the appearance, which is the phase 1. Actually, disappearance, which is phase 5. Korotokov sounds. But if you forget the name, doesn't matter. But appearance is appearance. So I'll just go through them. So I'll actually do what I said I'll be doing now. This is the second step. So there, working. Check. Okay. Right. So I get a pressure reading of 116 over 16. That's a pressure at which I hear sounds, start hearing sounds. So 84 at which I don't hear. The sounds disappear. Hmm? You will find that when you start hearing the sounds, the sound, the character of the sound will be different in different people. In some it will be quite loud, in some it will be faint. The pitch will be also different. So measure in several people to see, several of your colleagues to see whether you get that. Right? So sounds get louder. Once you start hearing, it's very faint when you start hearing, and you have to be very careful. Pay attention, because otherwise your reading is wrong, isn't it? If you wait till they get loud enough for you to hear even without the stethoscope, right? That's faint sounds, but then they get louder and then suddenly they disappear. So, yeah. So make sure your pressure comes down very slowly. That's why I wanted you to get used to this one. So that you don't have to move your hand at all. You have your bulb here in your palm. This will be pumping, and when you want to open, you can control very precisely the rate of right? Can you see? It has to be uniform, it has to be slow. Now this is too fast. That is too fast, because you can't do your reading, you can't be accurate if it is going too fast. Right? And another thing is, you don't do it's too fast, I'm going to make it slow. Too fast, it has stop all sounds, and so on. Stop and start, no. It's like a highway. Well, no, not like a highway, not too fast. Highway during rush hour, right? Slowly. Okay, right? Another thing. Remember, I said I'll do the. This is the second step, which gives us accurately the systolic and the diastolic. The palpation didn't give us the diastolic at all. That's right. Whatever the thing is. Supposing you do this, right? Okay, I'm doing the first step. Oh, yeah, I got it here, but I couldn't read it. So now what shall I do? I'll pump again? No. See what I mean? If I miss, it's quite all right to miss. Sometimes it's not possible. Then you release the pressure completely. You don't go halfway. Wait for a few seconds,